Hello, good afternoon, everyone. I'm Dr. Snehal. I'm fertility consultant. So today I am here in Onco conference, basically to make awareness about newer field which is coming in, which is the Oncofertility team. And this is nowadays a urgent unmet need because of the improved cancer survivals. Nowadays, our focus of treatment is shifting from just cure to the quality of life, and that's why we are having this interesting panel here forming Oncofertility team. I would like to invite my eminent panelist, Dr. Ranu Patni ma'am. She is senior consultant gynae oncology, Mahatma Gandhi Medical College, Jaipur. Then Dr. Somashekar sir, he is HOD surgical oncology, Bangalore. Dr. Garima, she is additional professor, obstetrics and gynecology department, AIMS, Jodhpur. Dr. Chandrakanta ma'am, she is assistant professor, SMS, Jaipur. Dr. Namita Kothari ma'am, she is chief consultant and fertility specialist, Asta Fertility Care, Jaipur. Dr. Neha Sethi ma'am, she is assistant professor, department of Oncopathology, Jaipur. Thank you so much for being a part. I would like to go ahead in the panel. So here we will try to have most interactive session where there will be a case scenario. And as we know how generally it goes, so basically at the end, what is the aim of our discussion is how we can form a based oncofertility team, which is actually a combined unit, combined teams of the oncology, meaning oncologist as well as oncosurgeon and gynae oncosurgeons and fertility team. Of course, they contain other things like counselors, psychologists that will come across as we go in the case scenarios. And the flow is generally first there is a patient which is meeting onco team, then they will have counseling about these oncofertility or fertility preservations, then it will come to the fertility specialist, then again they will go back to the onco team for the actual treatment, and once the treatment they are cured from the cancer, again they will come back to us for the pregnancy. So that way is the complete circle, and we'll discuss the points as we go on. So this will be based on case scenarios, how we provide the counseling, what are the options we give them for the fertility preservations, and how it is practical, how it is feasible, how affordable. So that is the forming referral pathways and what are the ethical challenges. So we'll go for the first scenario. So that is a 27-year-old unmarried woman, asymptomatic, diagnosed with CIN3 on routine pap smear. Now the cancer diagnosis is adenocarcinoma, stage IB1. So now we'll discuss different viewpoints. So now in the cervical cancer, what are the possible causes of fertility loss? So I think we can start with Ranu madam about enlightening about these things. So what are the possibilities of the fertility loss?
I don't think cervical cancer per se causes fertility loss. The only issue is the disease might flare up, or pregnancy is not affected by cervical cancer as such. But of course, once diagnosed, it has to be treated before you give a good outcome to the obstetric outcome, actually. But we have to consider oncological outcome also, which is the priority in any patient with malignancy in pregnancy.
Yes. Now, ma'am, in such a patient, so I would ask Dr. Chandrakanta, if now she is coming to you, it is the diagnosis, and then before planning the treatment, you want to give her the options for the fertility preservations. So what you would be counseling her?
Yeah, this is adenocarcinoma stage 1B1. That is, the tumor size is less than 2 centimeters.
Yes.
In this case, we can offer her the fertility sparing surgery. That is, laparoscopically, we can do radical trachelectomy. And after that, Because one more thing is there that even in 1B1 stage, there is chances of lymph node metastasis of approximately 15%, which is further increases at 30% in 1B2. So up to less than 2 centimeter, we can manage the patient and we can do fertility sparing surgery, and we can save the patient and give their parenthood.
Yes.
I would just like to add, before we go for any fertility sparing surgery, we have to fulfill certain criteria.
Yes.
So she is, of course, she's an unmarried girl and would like to save fertility potential, and she is in the reproductive age group.
Yes.
But apart from that, it is 1B1, so obviously 2 centimeter or less, and there has to be enough margin.
Yes.
Actually, at least 1 margin has to be there beyond the disease for us to be able to remove it. So it has to be favorable histology as well. You cannot do it in unfavorable histology. It has to be either squamous or adenosquamous carcinoma. You cannot do it in rarer or ones with poorer prognosis.
Sure.
So basically you have to fulfill the criteria for fertility sparing, and once those criteria are fulfilled, you can go ahead with a radical trachelectomy, which can be done with either route, either abdominal or vaginal, and you can also do it vaginally with laparoscopic lymph node dissection, or you can do it laparoscopically. So route is immaterial. We have to give her good oncological and obstetric outcomes.
Yes, and that of course will follow those criteria where she is fitting into those criteria. And next, then I would come to Dr. Garima. So what are the options for the fertility preservation in these this patient you will advise?
So basically, fertility sparing surgery, we all have discussed it.
Yes.
Besides just doing the surgery, I think it is very, very important to counsel her regarding the future fertility aspects. As in, spontaneous conception rates are good, but then she might need to go for some ART procedures in case she doesn't conceive spontaneously. And even if she conceives spontaneously, we have to explain her the chances of having a bad obstetric outcome in terms of miscarriages and preterm labors, because those are known with radical trachelectomy. Besides that, in case she doesn't conceive spontaneously, fertility preservation options would be to go for oocyte cryopreservation or embryo cryopreservation. These two are established fertility preservation procedures.
Yes.
So if we want to go for oocyte or embryo cryopreservation, that has to be done logistically. It is better to do it after surgery, because if you do it before surgery, then chances of spreading the malignancy and technically difficult.
Yes.
So ovarian cryopreservation and embryo cryopreservation are two established procedures available. And in case if you have not done a fertility sparing surgery in a properly selected patient, and post-operatively she has those risk factors for getting an adjuvant treatment. In that case, the ovaries have to be protected before the radiation is given. So ovarian transposition is one.
Okay.
So these are the options available.
Yes.
I would differ here in the sense that we, like she said, we have to do it after surgery. But so I think we can go ahead before
we can
surgery,
go ahead before surgery.
Because after that, then we would delay the adjuvant if needed. And we have to rule out metastasis before.
Correct.
You go ahead with fertility.
So I'll also
Namita,
if anything, any from fertility point of view, I was coming to that.
Actually, before advising her for fertility preservation, I think we must go in for her fertility markers, which are very important.
Correct. Yes.
Because presently we are facing lots and lots of patients of POI, that is premature ovarian insufficiency, even at the age of 25, 26.
Correct. Yes.
PCOS, in fact, has absolutely gone from the fertility. It is now POI. So before, giving her lots of hope for fertility preservation, her ovarian antral follicle count, anti-Mullerian hormone, these are the two important markers which are to be done. Then only we should go ahead.
We can discuss further options. Yes. Anything Dr. Neha wants to add?
As per a pathologist, I just like to mention that what the margins which Ranu ma'am has
correct, whether it's a free or
whether it is free or not, and we always look for the paracervical and paravaginal margins
correct
for it, so that you can do your procedures well on time.
Yes. So those points have been discussed. So as per pathology, so margin, it has to be free. Margin should be free. And madam has very well discussed about the fertility sparing surgeries. And of course, as you said, those fertility preservation options are to be discussed at the point of diagnosis. Even though, yes, it is difficult because it's an existential crisis for the patient. We agree that, but that's the role of the counselors and a complete team where we need to discuss those points before starting or before planning any treatments. And as a fertility specialist, as madam rightly said, we would want to know her basic fertility potential first by doing AMH and AFC, and accordingly we can guide her. And as she is unmarried, we can give her an option of the oocyte cryopreservation. Yes, there are other options. If the known partner, embryo cryopreservation, oocyte tissue.
What is her age? Age
is 27. Yes. So, and the ovarian tissue cryopreservation also can be done, but it was experimental, but nowadays ASRM has removed that label and we do it. Only requirement is we should have the institutional ethical committee for that, institutional review board. So that we will discuss in further. And so of course, and later on we'll come to it in the different cases, like later once the patient is cured, we again give her a chance for the spontaneous pregnancy. If it is there, we go ahead. If not, then definitely we come back to fertility by these options. So we'll go to the further next case. So it is a 15-year-old post-menarchal girl.
I would just like to,
yes.
Giving her chance for spontaneous pregnancy. I don't know what the other panelists think, because we don't need to waste any time in a known case of malignancy.
Yes. And
so we can straight away go for assisted reproduction.
Definitely.
Also.
And then that will be all planned based on her AMH. That is AMH and AFC.
That is
how much ovarian reserve she has. Because we don't know whether she would have required any adjuvant chemo or radiation. If that is the thing, definitely we should go immediately for the ART. And based on that, as I mentioned, even suppose the uterus is maybe radiations and all that, then there are problems with the uterus. There are recurrent miscarriages or recurrent failures also. IVF failures, and also other options like surrogacy and other things to be discussed in such a patients. Yes. So we'll move on to the next, which is she is a 15-year-old post-menarchal girl. Diagnosis is a scleronodular Hodgkin disease, stage 2B. I know, though the session is more of the gynec onco, but here my point is, it is still, the thing is, it is only for the gynec onco cases. Oncofertility is only for that. No, actually it is for each and every cancers. Especially, and this is because we are dealing with the young patients, young adolescent age group, and hematological cancers are much more in that. And that's why I've just put this scenario. We don't want to discuss much onco point of view. Of course, the plan will be given by the oncologist, but for the gynae, for the oncofertility point of view, we just wanted to discuss how severe is the risk of damage to the fertility potential. So I think anyone can comment on this?
So basically, even if this is a non-gynae cancer, but I think all gynae oncologists should be aware about what all chemotherapies are most gonadotoxic. Mm-hmm. So in Hodgkin's lymphoma, we all are aware that it is cyclophosphamide-based chemotherapy, and this is the alkylating agents are
highly toxic.
Highly gonadotoxic.
Yes.
So, but having said that, the cumulative dose of cyclophosphamide which is being administered is mainly going to decide how much gonadotoxicity that the patient is going to experience. So that is there. So since she is going to land up into this cyclophosphamide-based chemotherapy, it is important that with the diagnosis itself, the patient is referred to an oncofertility team, and then the fertility preservation options are discussed.
Yes, correct. Very correct. And just I would like to ask Dr. Namita. So as you said, the markers are very important because, as she said rightly, these patients also, because of the extreme catabolic stage, first of all, the reserve would be lower. So we don't know. Sometimes we have seen even the younger patients, AMH is very, very low. So in that, it is then very difficult. And ma'am, I would like to ask you and throw some light on about the counseling for such a girls, where if in case she is going for the oocyte cryopreservation, she will require ovarian stimulation and monitoring. So in that, and the approach for the, monitoring, whether it is a transvaginal scan, how it would be, and the approach for the oocyte pickup.
Yes, counseling we'll have to do, because definitely we would like to go in for a transvaginal pickup. We would not like to go in for any laparoscopic or abdominal pickup. So transvaginal pickup, we'll have to counsel the girl, her parents, and accordingly we'll have to start our protocols. And since we all are aware that now these random start protocols are not dependent on the cycle, you can start it immediately. And you don't even in fact have to wait for the withdrawal bleeding. And now we have these progesterone primed protocols, which are also very, very effective in these patients. So this is very important to counsel them. And plus it's very difficult on their part to understand also that how important this will be, because their main aim, because we do get referred patients at our center from the oncology department of SMS, and they hardly 1% materialize.
Correct.
So that is something, because their immediate concern is the survival of the girl rather than this. So counseling is a very, very important part.
Correct. That's why that is a very practical problem basically we are facing.
Actually, I would like to know from Namita, because I think in her case, she's a 15-year-old girl. The ovarian reserve will also be less, than it's a highly catabolic state. Then, then it's a chemotoxic regime that she has to be given. So what do you do before cryopreservation, or what are the procedures that can be followed for such a small girl?
Ovarian tissue cryopreservation should be done, but then this is a big challenge, because in India, I think 1 or 2 centers are doing it. And what is the outcome? Because all over the world, I think we have 82 to 83 documented childbirths.
Those documentations
after ovarian tissue cryopreservation. So we do get patients, and we have some oncosurgeons also inquiring from us that are you doing ovarian tissue cryopreservation?
So this is still in a research basically
process.
We need to work on it more and more.
Yes. So the only thing is that we will have to do her AMH, antral follicle count, give her a minimal stimulation of 9 to 12 days, and go in for oocyte vitrification. And then she can go in.
That is the current practical basically approach that we can, but more and more, because this oncofertility, I mean, it started almost like 10-15 years more in the Canada first, and they started their consortium and all those things. So I think there is a need, because they have a dedicated centers, they have a dedicated team, so there they can do it. So I think there is a need now to form such a combined units, and there should be the guidelines which are we have to follow.
And embryologist is a very important
important part of this team,
because there is difference between cryopreservation of oocytes
and the tissue. Yes,
ovarian
very
tissue
true.
is slow freezing, which is oocyte vitrification is rapid,
ultra rapid.
So therefore, embryologist is a very, very important part of this.
Yes, and later on there are the different techniques, like what we are going to do while we are using that tissue. Either there is a transposition, but sometimes in the hematological cancer we need to first find it out whether there is a metastasis.
Because I don't think in her case transposition is going to help.
Transposition, sorry, transplantation. I mean, I just missed the word. Orthotopic transplantation, where we are going to transplant the tissue again, but there are risks of the reseeding of the cancer cells, so that we have to rule out. And another things, again, we have like in vitro activation of the oocytes and in vitro maturation of the oocytes, but those techniques are in research, so we have to work on it more. Here, I put this case again for one more reason. So to discuss about what are the challenges in dealing with the pediatric cancer populations, because these are the major our patients which we are going to face. So here, basically, as I had mentioned, so these patients have basically experimental fertility preservation options. That is either tissue oocyte, the ovarian tissue cryopreservation, or testicular tissue for the males. So they require an institutional review board approval. And basically, children and adolescents, they lack the capacity to envision a future in which they want the children, but in adulthood regret a decision that not pursuing a fertility preservation when offered. So it is a very, very complicated and awkward situation.
I think we should have a legal person also in the team.
So we will discuss even the legal and ethical consideration of it. And there are ethical concerns when parents are making their generational decisions for their children, which is again ethical concerns. But basically, what are the required things are informed consent of the parents, which is very important. And here, of course, it should be very clearly mentioned. And from the oncologist point of view also, when the oncofertility counseling has been given, the documentation is very important, that such a counseling, these options were given, what patient and the parents they have agreed upon. If they have denied, yes, to be mentioned, and at least there has to be a counseling by the team, fertility team, as well as the counselors. And especially in the pediatric age group, we have a pediatric counselors which are there. So they will first make them understand what exactly is about the knowledge about the reproductive system, and then going forward. So definitely these are few points for the parental consent.
And the second last point, that fertility will be ensured in adulthood by preservation.
That is not essential.
This negative counseling we will have to explain.
Correct. Because yes, sometimes it is something that definitely 100% it will happen. It may not be, because it all depends upon how the cancer treatment goes, how is the prognosis, how is the cure, and later on what are actual conditions of the patient. So that is also there. And sometimes they think in a little different way, okay, fertility is going to be preserved, so this is going to be very good cancer outcome. I mean, that is also not there. So all those things.
And besides fertility, there are so many other challenges also in this population. One needs to worry about her puberty transition, menstrual health, sexual health, her psychological status. So many more challenges are
other things are also there. Yes, that we have to. So that's why the documentation and the consent from the child, that is also very important. And as I said, there are certain points where ethical reviews are required. I'll not go much into detail, but this is just to understand the workflow, and that is very important. So whenever the patient presents, the important is to provide the counseling by the primary team, and whether they have they want to go ahead, then yes, that consenting, and then sometimes the video consenting is also been done, and then the patients are referred to the fertility team. When the patients are pre-pubertal, in a male we have a tissue preservation testicular, in a female we have a ovarian tissue. These are the options, but those are experimental. Then pubertal, in a male it is easier, sperm freezing, but sometimes if it is azoospermia or any other problem, then testicular freezing. And in female it is oocyte cryopreservation, embryo or ovarian tissue. And even if patient has denied, we have to accordingly document.
Another problem with OTC is that when you transplant these ovaries back, you need to counsel that 50% of the ovarian reserve is going to get lost by the time the ovary is establishing the vascularity. So that thing also need to be, informed beforehand.
So, yes, absolutely right. Because that is why AMH and antral follicle count is very, very important documentation.
Yes, that is very important. And again, while they are starting a phase of the treatment, that time also, and from the beginning also. So that counseling, I think at every point of time, and realistic picture in front of the patient and the family, that is very important.
Counseling has to be modified according to her clinical picture and the circumstances.
Yes. And
to individualize it, right?
Yes.
Very true. Very true.
Yes, that also will come to it, key financial aspect. So I think we'll go to the next scenario. A 23-year-old man. This is for the male. I have just taken.
I think we should have taken a medical oncologist in the pathology.
Yeah, one medical oncologist for this. But this is just to cover all aspects basically. So and the diagnosis is AML. So again, I think, yes, Dr. Chandrakanta, if you want to add on.
Yeah. AML is an, in onco-emergency.
Yes,
so we
correct.
have to start treatment as early as possible. The options available are the, TESE. Testicular sperm extraction. This will be the best, and so as soon as we can start the treatment.
Yes. So first is a semen preservation, because I think Dr. Namita would. Semen preservation. Ma'am, you want to add on?
These sometimes semen preservation by masturbation. this is the
Yes.
best option. We have young, students who are studying in LN and all, they're competing for their career exams. And suddenly they are, diagnosed by this malignancy. And so they're being sent to us. So due to stress, they actually sometimes cannot produce.
Yes, that is a practical problem again.
So
Yes.
in these cases, we can do a testicular sperm extraction. That option is there.
Yes. Okay, so we'll not go much in detail. So we have the option, very simple, is the semen preservation if it is there, or otherwise TESE or OncoTESE, micro-TESE. Then this is another interesting case where 32 years, nullipara, there is a mass in the left breast, 3 centimeter irregular. There is a family history. So maternal grandmother is having pancreatic cancer, maternal aunt is having postmenopausal breast cancer, maternal uncle had melanoma. And the cancer diagnosis, so there was on biopsy invasive ductal breast carcinoma and ER positive 95%, PR positive 95%, and HER2 and U positive, and no nodes. So I think we'll start with Dr. Neha for this case.
Okay, as you can see, the patient is having multiple, the genetic history is also there. And
Yes.
so we will go for the genetic testing first.
Correct. Yes.
Most commonly BRCA1, BRCA2 and other genetic mutations are there. And as per the diagnosis part, we always do a true cut biopsy and put the hormones as well as HER2 to categorize them as per the their molecular subtyping, so that likewise the oncologist and surgeon will plan their treatment.
Correct. So here the point was importance of the genetic counselor and the genetic testing, and also fertility point of view. I'll ask Dr. Namita to put a light on it. What are the special precautions we take during the ovarian stimulation, because it is now hormone sensitive tumor. Yes.
So during ovarian stimulation, as we all are aware, there is rise in the serum estrogen levels, which may be detrimental to the malignancy part of this patient. So the protocol which we are using is obviously the random start, whether she's follicular phase or luteal phase. And we can start with antagonist 3-4 days and then give her the stimulation, or we can give her progesterone and then later on we can start. But most important is we have to add aromatase inhibitor, that is letrozole. And then recently only I have done this a case like this, and I've frozen her oocytes. And in this we gave her letrozole right from the beginning, and after pickup also for another 4-5 days, or even for 7 days, 10 days we can continue. It is a harmless medicine, and she did fairly well. We did not have any problem, and we could retrieve around 12 mature oocytes, which we have frozen.
Yes.
So this is very important that in these patients we have to add on letrozole even and continue after the pickup.
Correct. That is.
I think progesterone should also be given very cautiously, because she's ER and PR positive, and progesterone is known to increase the risk also. So
minimum
dose I think we should be very cautious in that, and letrozole of course.
Yes. So this was yes. Yes, later on.
In that case, what will you do? What will be the option?
I think cryopreservation before.
Then later on, she can have.
So in that case, I just want to know, can you preserve ovary as such?
Ovarian tissue.
I mean ovarian tissue.
Ovarian tissue. That's what. Experimental stage only.
Yeah, that's
because in that case
discussed in the stimulation and all these things, because she's hormone positive, right?
Yeah.
So any type of stimulation.
Yes.
Is really dangerous to her. So in that case, only ovarian tissue preservation, that's under study still.
Yes,
but
that
I think
is
that's
understood.
And because she may require prophylactic oophorectomy also.
So later on she can
undergo. Yes,
she can have prophylactic oophorectomy, but before that we have to do
vitrification of the oocytes
for fertility preservation.
Yes, so we can. Ovarian can be done, but still as it is experimental stage, though the experimental level has been removed by ASRM, but it is practically not that easier.
Actually, in India, we have yet to have any child born after
ovarian preservation.
Because it is still in the experimental phase. That is the main problem. In fact, we don't even if a fertility center, now we have the new ART law.
Correct.
So since
that is
June 2022, it has been gazetted. So there are multiple issues in that. Like previously, donor egg we used to advise. Now that is a big issue now. We have yet to have anything. Then second part is the surrogacy. It is banned from January 25th this year.
Yes. So
that is also big problems in these patients.
In BRCA,
that is
hormone positive breast cancers, where we do prophylactic oophorectomy. If she is an infertile patient and she and her ovaries can be kept till she completes her family, and then we can remove the ovaries.
Yes, so that is also the option.
Sorry? Even if she comes out to be BRCA positive and her ovaries are normal, and we are doing, she's already 32. She's already 32, so we can preserve her oocyte preservation, and then we can remove her ovaries there and then.
So not all BRCA positive are going to develop COV. That's not 100%.
Breast cancer risk reduction.
Prophylactic can be after completing the family.
And I think with tamoxifen and all these, I think you are a better person to tell about that. So,
okay. Yeah. So here basically what I wanted to discuss is the same stimulation protocol. So we have the GnRH antagonist. So so this gives basically very less minimal chances of the ovarian hyperstimulation, because that is also one of the deadly complications that we don't want in this patient. And yes, what is the different in the stimulation because of the cancer? Because already the HPO axis function has been affected. There is a fertility is already declined because of the malnutrition and the catabolic stage, as we discussed. And again, BRCA mutations, the oocytes will be having danger of a DNA damage. And definitely there might be requirement of the high gonadotropin dosages, which we have to manage. So basically we have to manage the stimulation well, where the estrogen levels will be very minimal. But definitely these protocols, as madam rightly said, it will not affect the oocyte quality or the number as compared to the conventional stimulation protocol. So this gives a very good result. And another thing just to mention here, because it's a genetic thing, as madam said, so we have to give the genetic counseling, testing. And definitely if the patient if she is going for the embryo preservation, if the genetic testing found out to be positive, we can go for the PGD, that is pre-implantation genetic diagnosis. So PGD I think
is freely available.
Yes, available. We can definitely do in such a cases.
Yes, we can offer them this and counsel them.
So that is also, so they will not that will not go in the future generation, that is. And as we discussed, so after completion of that, she can undergo risk reducing BSO. And of course now these disease modifying agents like trastuzumab or pertuzumab, they are contraindicated in the pregnancy. So during that time, contraception to be advised. And also there has to be a washout period after the tamoxifen. That is also very important. Of course, everyone knows that. And so basically, depending upon the size of the mass, again, breast conservative surgeries to be advised, that to retain the ability to the breastfeed. So these were the points. We'll move on to the next. So here it is like 29-year-old. So it's like she had a history of the repetitive chest pain, and there was a mediastinal mass. So basically it turned out to be primary mediastinal B-cell lymphoma. I know. So basically, again, here to point out what is the urgency of the treatment. Again, it's a hematological cancer. So yeah.
Again, it's an emergency, and we know that this is B-cell lymphoma. So both chemo and radiation patients
will be required. Yes.
So again, fertility preservation has to be, counseling has to be started.
Yes, so that point now we agree upon at the diagnosis, it is important. So this was just to put a light, as madam already discussed in the previous case, that there are different protocols which are random start. So that was initially when we were also starting this and talking to oncologists, not gynae oncologists, routine oncologists. So they had, so we have to wait till the menstrual cycle, then it will be so much delayed. You might take 15 days, 20 days. So practically it is not. So we can start it at any time, which is a late follicular phase, even even the luteal phase without affecting any outcome. So in these patients, we also have the option of something called IVM. This is practically done in vitro maturation, where we retrieve the oocytes little early and we freeze them at an immature stage. Later on, in vitro maturation can be provided. But of course, we need to take precautions here, because hematological malignancies will have like bleeding, thromboembolisms, risks of infection, and other anesthesia complications.
Yes, a complete medical evaluation, including PT-INR, is
yes, that is very important. Correct. So that we require a team. So we should have like a backup, everything, and then these patients can undergo the pickup and further things. Now,
is this pregnancy rate comparable with IVM?
Yes, it is little reduced. Little reduced, yes, not exactly medias, but available. So, but not reaching as per these things. Yes, role of the lab, embryology, and yes. So that is basically a complete. When we talk about the fertility now team, it is inclusive of the clinician and the embryologist, because almost it is 50-50%. So 50% when we work on the endocrinology and the procedures, they work 50% in the lab, and that gives the final outcome. So definitely the both has to be, it's equal almost. So that is there.
But I think IVM is going to pick up in this particular these particular malignancies, because it practically reduces the chances of,
even the hyperstimulation, then metastasis also. And another thing is time duration is less.
Exactly.
Yes. So that is there. 5-6 days, it is enough, and still we get a almost comparable outcome. Okay, so this is also interesting case. So 32-year-old, and she already has one child, and history of the right salpingo-oophorectomy done for stage 1A borderline ovarian tumor in the past, and then now left adnexal mass. I think I'll tell Dr. Anu to discuss about it.
So in borderline ovarian tumors, normally if it's bilateral masses, I mean, one has already been removed, you said.
Yes.
So we can go for a cystectomy, but the results are not as good, as the outcome is not as good as an oophorectomy. So she has completed her family. She is a 32-year-old lady. We can counsel her and go ahead with a oophorectomy also.
Yes,
for her.
but ma'am, one child, so we just have to ask.
Yeah, so that's a counseling part that has to be done. And we have to tell her that we can do a cystectomy if possible, depending on the imaging and so many other factors. And if that is possible, and if she is ready to take the risk for future, then we can go ahead with a cystectomy. Otherwise, I personally would prefer completion surgery.
Even I would not suggest any fertility preservation in this patient.
But ideally, yes,
one child is more than enough, I think.
So better just to give the options, but then more counseling towards completion of the surgery.
Definitely that is counseling, and
that plays an important
proper
role.
Consent and all legal advice and all future results have to be told her in detail.
Correct. Yes. So I'll go ahead because much less time. Okay, so I think I'll skip this, but I just wanted, so as the more challenges in the survivorship in these patients when it was not offered, fertility treatment was not offered. So because they have more concerns in the fertility issues and desire to have a family. So majority of these patients initially, when they were not offered, they had a regret. And that was a very, this thing. So I just have to make it a point that receiving a specialized counseling about the reproductive loss and the fertility preservation is associated with a less regret and greater quality of life for the cancer survivor. So that was one point to make. And here I think we will discuss what are the ethical and the legal aspects.
I think you can just enumerate these because we don't have a legal expert in the panel.
So
just,
we can just,
Namita, you want
to if madam wants to make
wanted to say that every onco-surgeon and onco-physician should actually, in their consent forms, should actually have an informed consent point that they were given an option of fertility preservation, because we are getting patients who say that they were never given an option.
Ma'am.
That's the most essential aspect. And for that, you need to have an infertility specialist and a gynae oncologist in the team of Oncofertility. So unless that is done, it is not going to be done.
that I'll come to it, that there was no option given and she had to take a donor egg, which was a very difficult for her. So those are the things. So that will come to it. One is a proper documentation. One is we, as now this generation of doctors, we have to decide now. We have to take initiative to form the guidelines actually in India, and the referral pathways which are feasible. The center has to be there, and we'll discuss the key points. So I'll just enumerate, I think last just 5 minutes. So basically, ethical concerns are, it has to be given to whom? So it has to be offered to each and every patient where there is a curative intent, definitely. And now again, financial consideration will come to this now, because still the insurances are not covering the fertility part of it. So we are still battling with the insurance companies.
Fertility as such is
not covered overall, because they consider this is non-essential part. This is a non-essential treatment.
Considered as a disease or pathology.
Yes,
but then fertility clinics are flourishing, mushrooming like.
But ma'am, there is no insurance cover. There is no insurance cover.
With this new ART
law again,
now
it is
people are shutting
less money probably.
Yes, yes. And the thing is, here again, insurances are covering disabilities caused by the cancer, but they are still not taking into consideration that infertility is one of the disability which is caused by the cancer and its treatment. So there is the battle that is still going on. NGOs also should support this. We have an oncofertility unit, so we do it at very, very minimal cost, and we also give some funds from the patients, from the hospital, some NGOs, and some funds from the patient. So that is
really
one.
nice.
Now the laws have come that they have to we have to renew the
Preservations
every
also.
10 years. So
Yes.
then it is not expensive at all.
Yes,
It is
yes.
only the first time
The usual cost of the stimulation and all. So we are trying to make it very easy.
Yes, now
because
it is very easy.
yes, more concern at the time of diagnosis, they have to go for whole cancer treatment, which is also costing a lot, and at the same time this burden, so it becomes difficult for them to take this decision. So we are trying to help it out. Again, dispute over the frozen gametes, embryos, and here it is the actual requirement of the good documentation. As madam said, the counseling was offered, whether they have taken it, not taken it, denied it. And when we freeze them, then we take, and after the death, what is to be done? So there's something called posthumous reproduction. Sometimes the patient, that is also one of the ethical this thing. If they have given the consent themselves that the gametes can be used by the spouse, then only it can be used. Parents cannot decide that, it has to be used later on. That is the only patient's decision. That is very, very important. So because sometimes
another thing I would like to highlight now, since the law has become gazetted,
yes,
we have to take the posthumous consent
beforehand. Yes, it is a beforehand.
That's
At the time of the freezing, because most of the time, yes,
divorces are nowadays very common. So if you
that is
the
also
embryo
very
and they are separated, then what to do?
With the embryos?
I had one patient in whom he was supposed to come for sperm preservation. But then during chemotherapy, they decided not to go. And during chemotherapy, went into acute kidney failure.
Yes. And
then the wife came to me that, did you freeze the sperm? Because I want to carry the baby, because we have so much of property on the in-laws side.
Yeah, so that is very problem.
So I think all the more that we should have
documentation. Yes.
Yeah.
So we need a legal team also.
Yeah, unmarried can give.
Parents will give.
Parents will give,
Parents
and if he or she is an adult.
Yeah. Later on.
If ideally for the unmarried, it has to be, they will give in the consent, whether it will be used by my spouse. Actually, parents cannot decide on the behalf of that's what unmarried. To be spouse, if known, actually the parents cannot decide. We had one case where the hematological malignancy, boy was 18 years, so adult to give the consent. He has, he has ticked on the consent that not to be used, but parents were requesting that if you have a sample, then we will use it and all that. So with the legal team and all, we had the counseling sessions. We showed no, it is the person's choice. What is to be, the parents cannot decide.
Spouse's choice.
Person's choice.
Person's choice. The
Whether
patient's
gametes
choice.
can be used or not. Yes, but there also the consent also, but there also parents, that is not, if the only for married patients they can decide whether it can be used by my
But
spouse.
she is asking for unmarried
So
girl.
unmarried cannot. No? Then
So
they
if less
cannot.
than 18, parents have to give the consent.
I
Yes.
said parents
Because
have to.
then we face this issue that aap bachche ko mat batana, but then we
But
have
we
to
have to tell.
explain them.
We have to
Because
explain.
now with social media,
But I think
children are quite mature.
yeah, and I think
They
there is
know
one
everything,
point,
they
if I am
understand.
not wrong, that parents have to, the consent of both is
Both.
essential. Parents' consent and,
And
the child's
Child's
consent.
consent. That
If
is
the child says no, you
Then
cannot
you
go
cannot.
ahead. Whatever
Still,
it
ma'am,
is, she
with
has,
the
child
pediatric
has to.
counselors.
Yeah.
the social
Yes, with the
platform, they are
pediatric
very,
counselors.
mature to understand all these things.
So in that case, consent of both
Consent
is.
that is, a child's consent is known as assent if it is a less than 18 years, and that has to be documented, and with the pediatric counselors. So yes, we had that posthumous reproduction, so but this was a consent which was given. So the couple were undergoing, so first IVF cycle was failed, but the sperm was frozen, and the consent was given that if in case of death or anything happens, spouse can use. So with that consent and with the legal again affidavit and all that, we can use. So here it matters about a documentation.
Consent at the first.
At first go itself. We cannot take a consent which is later on.
Because
and ideally,
nowadays, since this law has come, I think we all are taking this consent.
Before, yes.
For any patient, irrespective of the.
And especially, ma'am, here we prefer video consents also, because that is very safe at the time, and everything has been noted, and proper counseling has been recorded.
Other than the signatures, the thumb impression
is also important. Yes. So those are certain.
Actually, legal and all aspects are to be considered. It's not so easy.
Yes,
That
we
has
have
to be saved till 21
Has
years
to be
ideally.
saved. Yes.
And
10
for
years, law says 10 years.
law says 10, we keep it as we have made this in 21. But ma'am, alive. But ma'am, for oncofertility, because it's a long-term
What
freezing.
happens if the treating doctor is no more there, like me, aged? So then what happens? What do you do?
The center has unanswered questions. So yeah, so basically it's a joint project of the couple. So definitely it is big this thing, but with the documentation, so we do that. We have done one such a case, and that came out well. And as I was telling, there was one where she was a doctor, pathologist by a profession, and at the age of 26 years there was a breast cancer, but the counseling was not provided. So she had a lot of problems. Her AMH was very low, and she went still with a self cycle, but there was a miscarriage. But taking a donor again was a very thing. So it is very important to provide such a counseling. So I'll just put one last thing. What is our goal and how we can have the ideal oncofertility setup. So there should not be delay in the appointments. So it should be as accessible, as early as accessible to the patient. So there has to be good time to time coordination with the fertility and oncology team. And of course, as we use customized stimulation protocols, then good advanced cryopreservation unit, so good embryologist and lab, and basic to advanced fertility treatment facilities under one roof, so that patient should not have to go for one center to other center so many times. And this availability should be like super specialty team should be available 24/7 as no delays, and genetic testing, genetic counselings and everything to be available. So this is ideal model of care which is given by ESHRE. So where a complete circle like oncology team, fertility team doing the fertility preservation, going back to the onco team, and again coming back to fertility team for pregnancy. So actually this is the complete circle. And hopefully as we are doing this oncofertility discussions and all, we should come up with such a consortium in India. Actually that is really urgent unmet need what we feel, and we have started doing that work, but it requires at a mass level, I guess. So
yes, I think it's sad that we have such sparse attendance, but this is a very, very important aspect of oncology. And with more and more women planning late pregnancies and more cancers being diagnosed in younger age. I
correct.
think this is a real-time
Very
issue,
important.
and we need very consolidated and focused
Also, I
management.
think public awareness is
Awareness
very
is more.
Yes.
We need to do some
Yes.
activities for the
Yes.
general public.
General
Definitely.
public
Make them
also.
aware of these options.
Yes.
I think we had once talked about it.
Yes, yes.
So thank you
COVID,
so
you
much.
know.
Yeah, cool. So thank you so much
thank
for
you
very
much.
nice
It was
discussion.
very nice panel.
And just to make yeah, please. On.
I'm Dr. Santosh, medical oncologist from Hyderabad. I really enjoyed the session, learned a lot of things. In oncology meet, I especially wanted to attend, although this was the last, I came here to attend this.
Thank you.
So I felt very
Thank you
useful.
so much. Thank you.
So I just want to tell our oncologist perspective. I think
Yes.
one person currently passed, one oncologist should have been there in the panel.
Yeah.
So what
Yes.
my thinking whenever I send to Oncofertility is, how is the malignancy curable?
Correct.
Highly curable? How urgency is the treatment? These are the two things. First, I have to decide that, yes, this patient deserves proper oncofertility.
Correct.
So first, doctor has to be convinced. That
Yes.
depends on the curability of malignancy and how aggressive I have to start the treatment.
Correct.
Second point is, after I decide, when I counsel the patient, almost, madam, in my practice, only 5 to 6% would turn up to oncofertility. After turning up, then the duration and all, they will...
Hardly one will materialize.
Yes,
actually.
madam. It's very
again,
difficult.
Practically.
So that is one aspect where,
Especially females, females.
Yes.
For men, it's not so difficult
yes.
because
Yes, especially
for
females.
females, it's an invasive procedure.
Yes. Yes.
I think partly that is also because there is so much of fear for cancer even now.
Yes.
The word cancer spells death for them. So they do not believe that they have to focus on any other issue. It's
Correct.
just like cancer ka treatment ho jaye kaise bhi. So there are lots of other holistic things that have to come into picture. And you're very right that we have to make this a more concentrated effort. You know?
As we have discussed the second case, Hodgkin's lymphoma, the cure rate is more than 95%.
Correct.
That is the ideal patient for
To go for it. Yes.
the next case, acute myeloid leukemia. In that case, I would not myself push towards
Much.
that. Might entertain more legal troubles also, because the survival in acute leukemias is very, very minimal,
Yes.
and they have a lot of platelet dysfunction and
Correct.
all these things. So
Yes.
that case, we would not likely to push ahead. But Hodgkin's lymphoma and young breast cancers, we would push.
Definitely.
This is one aspect. The second aspect is that was briefly touched, especially those who are BRCA positives. Those patients, whenever we push for fertility preservation, they would think about the next generation. Suppose my egg would have this.
Same.
So
Hereditary.
So
Yeah.
I just have it out, the pre-implantation diagnostic. How widely is it available, madam?
It's very
It's-
routinely
Okay. So we'll test the embryo whether it has the mutation or not.
and
Okay.
very routinely available, very routinely done. And nowadays it has, I mean, it is not a new procedure at all. So yes.
And one more thing was, whenever I counsel the family, I had a patient who has BRCA positive. She's around 50 years, has 3 daughters. I've advised that high chance of BRCA penetrance,
Correct.
you should to test in your 3 daughters. She gave me, शादी के बाद कर लेते, पहले शादी होने दो सर, जो भी है बाद में कर लेते.
Social
Cancer is a stigma. Even
Yes.
hereditary is a stigma.
Stigma.
So
and
we have to overcome that first. Yes.
I had a patient yesterday. 4 members already are affected in the family. Then also she got married.
That is the other.
Marriage
That is
is
a social stigma. Yes.
How early can we do, madam, if I send a lady matlab, for this one antagonist? How early you can?
It is an immediate start. Now we don't want to wait for the periods at all.
Suppose I send a patient for
Same day. We can start same day because in such a, like in our unit, it is in-house, everything in-house lab. When she comes, we decide, we do the lab, we get report in 1 hour, AMH and hormonal profile. LHT2, FSH, and immediate same day also we can start. Minimal like 9 days. Yes.
And then we immediately start the program.
9 to 8 days or 9 to 10 maximum.
10 days.
10 days.
So after collection, how early we can start the chemotherapy? Because platelets tend to fall after our chemotherapy.
Within a week, you can
Week next.
I mean, actually, within a week also, but immediately as such, transvaginal oocyte retrieval, it's not like a big surgery. It's just one prick. So even immediately, there is no surgical as such, you need not.
So maybe by 2 weeks we can.
Yes. Maximum 2 weeks from your
Maximum.
side. Yes.
Thank you very much.
Thank you. So thank you so much. Yes. And for the oncologist, we had this Oncofertility manual, which we had published in 2020. Yes. Yes. So you can just have a look. That is mainly for the clinician that we had made from our department as an effort. That book is available.
Share it.
Definitely, I'll share the link on the. Definitely. And thank you so much for being a
Thank you, Dr. Snehal. As a pathologist, I was an outlier, but I understood each and everything. Thank you.
Thank you.